Good evening. Very warm welcome to this inaugural lecture given by one of this year's new professors, Professor Robert Kirby. As is our wont on occasions like this, I think it's worth just reflecting a little bit on what inaugural lectures are all about. They are very much an important part of the university calendar, giving us an opportunity to show off some of our best research and our best researchers to potentially a wide audience. And that's one of the reasons in particular why it's very good to see such a wide-ranging audience here this evening. So from a university perspective, it's a very, very important event. But for the individual concerned, it's also a very important event, if not a somewhat daunting one, in order to be faced with that wide audience, to pitch a talk that is intelligible to people from all sorts of backgrounds is not a straightforward thing to get right. And so they do take a little bit of work, and they do take a bit of effort, and there's no doubt a little bit of nervous energy just on my left-hand side just at the moment. So they can be very, very tricky. And some of you may have said, I heard me say before, I think one of the other pleasures is that if you're in a situation where you're fortunate to have members of your family in the audience, you don't often have the opportunity to give an academic lecture to members of your family. I sometimes reminisce on my inaugural, where my then, I think, 6-year-old daughter was there, and the one good part of that was that she laughed at all my jokes. In fact, the biggest joke of the evening became the fact that she was laughing at all my jokes. So it worked through very, very well. You've come here to hear Rob. So I just want to very briefly run through Rob's CV. I haven't picked out all of the peaks. It's very much a straightforward record of the fact that Rob qualified in 1977, and after house officer posts in Birmingham, he worked in the southeast at St Mary's Hospital, at Great Ormond Street, and at Red Hill General Hospital, before gaining his FRCS in 1981. After a surgical rotation between the Royal Surrey County Hospital in Guildford and St George's Hospital, he became a research fellow in transplantation in the liver unit at Queen Elizabeth Hospital in Birmingham. He moved to Stoke in 1986 and was appointed as a consultant general surgeon to what was then the North Staffordshire Hospital in 1991, and as clinical senior lecturer at Keele in the same year. He was the first director of admissions in the new medical school. He was undergraduate director of surgery and was appointed hospital dean of the University Hospital in 2009. Now, despite not having allocated time for research in his job plan, he has indeed written and contributed or led to many, many publications. I have a number of more than 62 on my note here, largely in the areas of breast cancer and in colorectal disease. Now, indeed, the UHNM breast cancer team, who I assume there are other members of that team present this evening, is one of the largest recruiters of patients into clinical trials within the hospital, and Rob himself considers and prepares patients for consideration of entry into those clinical trials. And for example, one of his current enterprises is as principal investigator for a study assessing arm lymphedema after axillary node clearances. So reflecting those interests, activities, and indeed his expertise, tonight's lecture will look at 3 areas. It'll describe medical and surgical training in the 1970s and the 80s and compare it with training today. And we are promised, I think, a little bit of a consideration of the impact of working hours for trainee doctors, which is clearly quite topical. Rob, I think, is also going to consider the modern management of patients with breast cancer and comparisons made with previous management approaches, how the research will develop, and indeed what are the opportunities going forward. And then finally, Rob is going to talk about the development of the medical school at Keele. Clearly very, very important for the university as a whole, and he'll put some specific emphasis on the student learning in clinical environments. Can I therefore formally welcome all of you, and formally welcome Robert Kirby, our Professor of Clinical Education and Surgery, and invite him to present the inaugural lecture, A Surgical Journey, a Timeline of Advancement in Surgical Training and Cancer Treatment. Rob.
Thank you very much, Vice-Chancellor, and thank you, everybody, for coming. Just looking around the audience, I'm quite bowled over by the number of people who've made the effort to come here. Colleagues, students, friends, family, patients, thank you very much, all of you. So what I'm going to talk about this evening is learning from experience. And I'm going to talk about the experience that we all get as doctors and how we apply that experience to how we manage our patients, how we manage the decision-making. I'm going to be talking about that experience with the development of the 1990s Trauma Centre, going back in time, 20 years. Coming forward in time, I'm going to be talking about the modern surgical management of breast cancer. I'm going to be talking about some of the work that we've done at UH&M. I'm going to briefly talk about surgical training, and I'm going to be talking about the development of Keele Medical School. Now, none of the work that I do is individual. It's all with other people. And I'm really lucky. I work with a great bunch of guys. I've got to say that, haven't I, as you're all in the audience? But it's true. Great bunch of people. I'm really lucky. And it's these teams that are doing the work that I'm going to be talking about. As Vice-Chancellor said, I trained in Birmingham University Medical School. It's interesting going back there now as an external examiner and seeing how things have changed over the last quarter of a century. I spent a couple of months at Johns Hopkins Hospital in Baltimore, and I'll be talking about that hospital a little bit later. There's the standard picture of the dark hair and the sideboards. Everyone has to show it. I did the standard sort of training that people did in those days, quite a few years, going around different parts of the country, gaining an experience. And when you're a young surgeon, you gain experience in more than one ways from the different consultants you work for. And I've put up a few surgeons who are particular inspirations. There's Paddy Bolter. He was a general surgeon, but he was also a breast surgeon. And he was one of the people who got breast screening started in this country, along with Sir Pat Forrest. There's Mike Bailey, one of his colleagues. He was a gastroenterological surgeon. Now, Mike was absolutely fastidious about his surgery. I learned a lot about surgical techniques. He was fastidious about care of the patients. As a surgical registrar, you knew if you didn't know your patients, you had an orchidectomy on the ward round, and the surgeons will understand that. But he was also a man who showed that you could be a surgeon and you could dress well. And then there's Paul McMaster. Paul McMaster, he was a really good surgeon. He set up the liver unit in Birmingham and turned it from a unit that was just doing a few transplants a year to one of the best in the world. I spent a couple of years with Paul. I wrote my thesis there, got some papers, but in surgical terms, I learned to operate around the liver, I learned to operate around the retroperitoneum, look after the sick patients on the liver unit, and also learnt a lot about research and research methods. I owe him a huge debt. The other inspiration is my father, Norman Kirby, who's a surgeon. He was director of army surgery, and when he retired from the army, he became consultant in charge of casualty at Guy's Hospital, and so I had always something to look up to. I'm a general surgeon. That means that I'm a soft tissue surgeon. Now, nowadays, general surgery is divided into subspecialties. There's upper GI, there's colorectal, there's breast and endocrine, and there's vascular, which is actually now a separate specialty. A lot of us, there are over 30 general surgeons in our hospital. It wasn't like that initially. There were initially 8 of us. And because there were only 8 of us, we had to do everything ourselves. Wide range of subjects. I was lucky to be in at the beginning of the laparoscopic revolution, do the first laparoscopic cholecystectomy in 1991. But like all of us, we did all the different subjects. But what I want to talk about, first of all, is the abdominal trauma. When I was appointed as a consultant, I was asked by Professor John Templeton, who was the Dean of the Postgraduate Medical School at the time, to visit California and visit some of the trauma centres, because Stoke had been asked to be one of the pilot centres for the Department of Health. And they wanted to look at the North American trauma model. And the reason they wanted to do this was basically a report from the College of Surgeons which had looked at 1,000 trauma deaths, 500 of whom had died in hospital, 170 were potentially preventable, and 63 of those patients had bled to death. And what was sad was that had followed a study from America 10 years earlier, which had shown that most preventable deaths due to trauma are the result of inadequately treated abdominal injuries. Now, in America, trauma surgery is a subspecialty of general surgery. Life's a bit different in America, so is death. Lots of penetrating injuries. Whereas in North Staffordshire, it's slightly different, a lot of blunt injury. So what we wanted to do was look at the impact of the emergency workload on what we were doing in general surgery. We were basing that on approximately 2,500 admissions annually. And what we found was that trauma admissions only comprise about 2% of our emergency workload, so not a huge amount of work in terms of numbers. For the severely injured patients coming through the door of casualty, general surgeons were involved in approximately a quarter of those patients in assessing and treating them, but we were only operating on less than 10% of those patients. So we concluded from that there wasn't enough work in the United Kingdom, certainly in this area, to justify specialist trauma surgeons. But the thing that we did show was that when our intervention was needed, it was needed fast, and we could make a difference by operating on the patients and stopping the bleeding. Now, looking at some of the techniques that were used in those days, the state-of-the-art way of investigating the abdomen, if it was suspected there was trauma but no proof, was something called diagnostic peritoneal lavage. And what that meant was if a patient was injured, you'd make a small hole in the abdomen, put in a catheter, and see whether there was bleeding. And if there was bleeding, you would assume, yes, there's something going on, we need to operate. Now, some of us didn't like that, so we encouraged the use of this machine. This is an ultrasound machine. This is an ultrasound here, showing free fluid, which is blood. This is the spleen in 2 fragments, and you can see the spleen in 2 fragments here. Now, the thing about this machine, important bit right at the bottom, these are called wheels. And those wheels meant that that machine could be taken to the patient. And that was important because at its time, the CT scanners were very slow, they were cumbersome, and the patients could be in there for an hour or more. And there could be catastrophe with the patients in there at that stage. So ultrasound seemed to be the way forward. So we compared the ultrasound with the state-of-the-art diagnostic peritoneal lavage. And what we found was by using repeated ultrasound assessment, we brought up the sensitivity to 89%. In other words, of 100 injuries, we thought that we were picking up 90% of them. And that compared with sensitivity of just 82% for diagnostic lavage. But the other thing was, because diagnostic lavage just told us there's a bit of blood present, it didn't tell us whether it was important blood. Now, that sounds a bit silly, but it meant that we were sometimes going in to operate on these patients and finding a little bit of blood, but not enough to actually require an operation. So we were doing things that didn't need to be done. But the other thing about the ultrasound was it meant that we were able to identify fairly trivial trauma as such and decide not to operate on them, and that was just as important. And when we looked at that effect on the spleen, we were doing less splenectomies than we did before the introduction of ultrasound. Now, the importance of this is if you lose your spleen, you're more likely to get infections with pneumonia, meningitis, and other unpleasant infections. So by preserving the spleen, we were reducing the risk of infections. I would hate you to think that was state of the art now, though. I'm talking about 20 years ago. This is a modern spiral contrast CT scan. That is free blood lying over the liver there, and there's a spleen, again, in 2 halves. ruptured, and actually that patient did come to surgery. So overall, when we looked at what we were doing, we found that with the introduction of the trauma system, we were decreasing the mortality of patients with major injuries. And we went from 26% to 13% over that time. And those people who were dying were mostly the elderly or people with head injuries. But the really important thing was that hemorrhage was no longer a common cause of death. Now that was used for a second College of Surgeons report and another report for the NC-POD, and eventually formed part of the body of evidence which led to the formation of a national trauma system. And there's a picture of the helicopter in our modern hospital. So coming back to the general surgeon in the 1990s, doing a bit of everything, and a bit of everything, as well as abdominal trauma, included cancer. And it was a bit of cancer of that, a bit of cancer of the other, a bit of cancer of the other. And there's some of us who are getting more expertise in one cancer than another, or a group of cancers. But what was undeniable was that around the country, some cancer care was actually pretty poor, because some people were dealing with cancers with just few numbers, and there was a huge variation. And so Sir Kenneth Calnan, who was Chief Medical Officer, and Dame Deirdre Hine, brought out the Calnan-Hine report, which instigated the development of specialist teams. So not just individuals dealing with cancer, but whole teams deciding on the treatment of cancer, and setting up cancer units and cancer centres to deal with it professionally in large or significant numbers. People who deal with breast cancer might recognize this picture. This is a picture by Rembrandt using his girlfriend as a model, his mistress, and this is a bathing of Bathsheba. And you can see the distortion of her left breast, and it is thought that this lady had a breast cancer. Breast cancer is one of the most common cancers in the United Kingdom, about 58,000 women diagnosed every year. And that means 1 in 8 women in the United Kingdom are diagnosed with breast cancer. And although 11,500 women die of breast cancer, the survival is actually improving. And there are 690-odd thousand women who are living with and beyond the diagnosis of breast cancer. And this graph shows the increasing incidence since the 1990s, and the mortality starting in the 1970s here, going up, and then in the 1990s starting to decrease. Now, whether that's because we're picking it up earlier, or because we're treating it better, or a combination of the two is up for debate, but we are getting better at it. The surgical treatment used to be very, very unpleasant. And with this picture, you can see this poor woman in the 18th century, being treated by amputation of the breast. Pretty macabre. And the irons heating the fire to fulgurate the bleeding wound at the end. Now, for the surgeons in the audience, there's something else that's pretty scary, which is that person there who's a physician telling the surgeon what to do. Nowadays, that's an oncologist. Really, things started to change when William Halsted introduced the radical mastectomy. And this was a scientific way of dealing with breast cancer surgically. And it was a big operation, taking the breast off, together with the underlying muscles and the lymph glands draining the breast. And he was operating in Johns Hopkins Hospital, which is where I did my student elective, where all the surgical wards were named after him and all the medical wards were named after Sir William Osler. And you can see this picture here. There's Halsted operating in his operating theatre. And this was a proper operating theatre. It really was a theatre with banks of students all watching and admiring. But the other advantage that he had was this, which was anesthesia. And that was a mask with either ether or chloroform, so the patient was asleep while he could operate. The next big advance came with Bernard Fisher with an American study showing that the survival after breast cancer didn't depend on having necessarily a mastectomy, but having adequate surgery. And in fact, the survival after breast cancer is the same after a wide local excision, taking the tumour out with a clear margin, and radiotherapy. And that's as good as a mastectomy for most patients. In America, despite that, there were still radical mastectomies being done. Nancy Reagan, for example, had a radical mastectomy. But nowadays, wherever possible, we try and treat breast cancer with breast-conserving surgery. Now, as well as that, there's the backup treatment, adjuvant treatment, hormonal treatment, radiotherapy, chemotherapy, monoclonal treatment, drugs like trastuzumab or Herceptin. I'm not going to talk about the backup treatments. I'm just going to concentrate on the surgical aspect of treatment. This complex slide is from the breast screening project, and it's looking at the overall detection rate. We're picking up 8.7 per 1,000 women screened in terms of malignancy, and within those figures, a 6.9 per 1,000 invasive cancers. And if you look at that figure, it isn't that far off what we were first picking up in North Staffs when we introduced breast screening in 1989. And this is really the work of Ian Gray and Mike Skinner. 6.5 per 1,000 women screened. But what's also interesting about looking back then was we said regular combined meetings with all disciplines have been found useful. And this was the precursor of the multidisciplinary meeting, because until then, it was individuals making decisions about treatment. And I think that we were one of the units that started leading the way in terms of a number of different doctors and nurses and radiographers sitting down and talking about the patients and making the right decisions as a group. And here's the group at present. Well, this is how we were, how we are now. This is a few years back, but it's with nurses on the ward, junior doctors, medical students, and a more recent one with our junior team. And being a surgeon, of course, I work in the operating theatre. So again, nurses, anaesthetists, surgeons, students. And just around the corner from this photograph, there's another piece of equipment. And this is an X-ray machine that we have in theatre, which X-rays the bits of tissue that we remove. Now, I'm going to call this Faxitron. It's a bit like calling all vacuum cleaners Hoovers, but that's what I think of it. So this machine, we'll call it Faxitron, is containing a piece of breast with a cancer in it. And that's the X-ray taken. Now, you can see that this was a cancer picked up by breast screening. You can tell that because it's one that we couldn't feel. We couldn't feel it, I know, because there's a wire in it which has been put in by the X-ray doctors, the radiologists, to mark the cancer there. And we've taken the X-ray, it shows us we've got the right bit, and just as importantly, it shows us we have a margin of excision. And that's important, because what you don't want to do is take a breast cancer out and leave it at the edge. Now, although the machine was brought in for use with the impalpable cancers, the small ones you couldn't feel, we also wanted to look at how that worked with the bigger ones where the patients had found it themselves. And what we found was that by using this Faxitron, we reduced the incidence of where we had to take the patients back to theatre on another occasion to clear the margins from 28 to 12%. And we also found, because we were more confident in its use, that we were taking out less unnecessary breast tissue, so we were actually removing smaller pieces of breast. At one time, we were being criticised in North Staffordshire because we had a high mastectomy rate. And for the screen-detected cancers, which are the smaller ones, we were running a 34% mastectomy rate compared to a national average of 28%. When I looked at my own figures, overall, taking all comers, it was a 52% overall mastectomy rate. So I wanted to know, why are we doing so many mastectomies? And what we found was that the majority, 64%, had actually been offered breast conservation. And the reasons that they were choosing to have a mastectomy was either because they felt safer, they wanted to decrease the risk of having to have further surgery, or they wanted to avoid radiotherapy. And that was an important lesson for us, because that told us that we were not persuading our patients that it was just as safe to have breast-conserving surgery. So a few years on, you can see how things have changed. Those are the numbers of breast cancers annually. Those are the wide local excision numbers going up, mastectomy staying fairly constant. And you can see the ratio of wide local excisions to mastectomy is increasing. That's my own series, but if we look at all the patients in Stoke, the last year we've got complete figures, we run a 34.5% mastectomy rate, and if you look at the small screen-detected cancers, we are just the same as national average. I apologise now, it's going to get a little bit technical now. I'm going to talk about the axilla and the importance of the axilla. If there's a cancer in the breast and it's going to spread, the first place it usually goes to are the glands under the arm. So if there's disease there, that can spread further. So if we identify that there's disease under the arm, that gives us an indication that we should be more aggressive with our treatments. And there's a changing pattern of treatment of the axilla. In the 1990s, amongst a lot of surgeons, it was thought that the best thing to do was to take all the glands out of every single patient. An alternative way of thought was that you'd just do a 4-node sampling, take 4 random glands out and see whether it's involved. But on the background of this, with the screen-detected small cancers, 25% of them were involved, but 3/4 were not involved. So if you were taking all the glands out, you're actually doing unnecessary surgery on 75% of the patients. And that's important when you look at what axillary clearance can do. It can cause pain, it can cause numbness, it can cause stiffness of the shoulder, and it can cause this horrible condition called lymphedema, swelling of the arm. So some of us took on a selective approach, which was tried to make the decision, second guess, is it better to take them all out or just do a sampling? And that's what we did, and we looked at a group of patients where we'd taken on this approach. We found that using this, 46% of our clearances were positive. There was some arm swelling, although actually very little true lymphedema. But not surprisingly, there was more arm swelling after a clearance than after sampling. And that was pretty obvious, but we just showed it. So what do we do at the moment? Any patient with a diagnosis of breast cancer, first of all, has an ultrasound of the axilla. And this is a picture showing an involved big lymph gland in the axilla, so this is suspicious. And then our very clever radiographers or radiologists will take a needle core biopsy, send it away to be examined under the microscope, and tell us whether there's cancer in that gland or not. If there is, then we proceed to an axillary clearance. If there isn't, then we do something else called a sentinel lymph node biopsy. And that's using a couple of different technologies. It's using radioisotope, technetium colloid injected into the breast, and this is a scintigram showing where this has been injected into the breast, going into the lymphatics and sitting in the lymph glands. And then we can identify the site of that with a probe, Geiger counter, picking up those hot glands. As well as the radioisotope, we use blue dye, which is injected into the breast at the same time, and that goes into the lymph glands. So we find the radioactive blue lymph glands and take those out. Those are the sentinel nodes. And what we found when we analysed them, first of all, was importantly, nearly 80% didn't require further surgery. So just taking 1 or 2 glands out, that was a huge advance. And then, which sort of cancer was more likely to be positive? The more aggressive ones, the grade 2, the grade 3, the bigger cancers. And surprisingly, the lobular cancers, which is a different subtype of invasive breast cancer, which is found in different parts of the same breast or sometimes on the other side. We did a small study which showed that depending on how you do the massage once the blue dye is in, we could pick up more cancers by changing our techniques. Sorry, not more cancers, more lymph glands. And we assessed how we're actually doing with the axilla using ultrasound and needle core biopsies. And we found by using these, the sensitivity of pickup of cancer in the lymph glands was 75% if you looked at all tumour types. But the lobular cancers, again, just a third of them would pick up, whereas the other tumour types were nearly 80%. So we knew we were being fairly accurate by using the axillary ultrasound. And then we wanted to know, is there a way that we can analyse these lymph glands at operation? Because if you find a positive lymph gland, then you can make a decision whether to go to an axillary clearance. And we used a technique called OSNO, one-stop nucleic acid amplification. I'm not going to go into this into a huge amount of detail, but basically what happens, we take a central lymph node out, that is sent for analysis in a special laboratory that we've built in a broom cupboard in the operating suite, and it's analysed there and then, and we get an answer. And it's a scoring system, and if the scoring system comes up as 5,000 or more, then we know that we've got metastases, in other words, cancer within the lymph glands. We then have to think about treating further. To begin with, we wanted to assess how we were doing with the same lymph glands, both by standard technique, looking at it under the microscope, and with the OSNO analysis. So we're slicing the same glands up and sending half for histology and half for the analysis in theatre. And what we found was we were actually picking up more disease on the OSNO analysis than on histology because it was looking at slightly more tissue. But those patients that have been found to be positive, they didn't have to come back for a second operation because we could decide to go on there and then. And when we looked at more patients, then we found that we were picking up about an 18% positive rate, and these patients went to axillary clearance. But things are changing. And the question that we're now asking is, do we always need to go to an axillary clearance? And the background for this is twofold. First of all, there's something called the 011 trial, which is a slightly flawed study from America, and a lot of English surgeons and oncologists are slightly unhappy with it. But that suggests that you may be able to leave the lymph glands behind once the sentinel nodes have been removed, even if they're positive. More importantly, there's a trial which shows that if you irradiate the axilla rather than operating on the axilla, you may get as good a result, but with fewer side effects of the arm stiffness, the numbness, the lymphedema. So what we wanted to do was actually look at the lymph glands that we were removing and see if there's a difference between the ones that we had picked up initially on the ultrasound and the ones that we were picking up in theatre that had had normal ultrasounds but were then subsequently shown to be involved. And this is a slightly complex concept. So this group of patients here was shown to be positive on ultrasound with a needle core biopsy. And what we found after operating, there was a median of 3 positive glands, and 49% of them, nearly half the patients, had more than 4 involved glands. Now with the OSNO group, it's slightly different because these are patients who had already had their sentinel nodes removed. So this is looking at additional glands. And what we were finding was the median of additional involved glands was actually 0. So there are a lot of patients who had no extra involved glands, although 19% had more than 4 glands. And you could postulate from this, especially taking into account the other series, that removing sentinel lymph nodes from OSNO patients might be enough to treat all the disease. We then wanted to look at the effect of different operations. The difference between patients having mastectomies or wide local excisions. Now, patients having mastectomy are usually ones with bigger cancers or with lobular cancers scattered throughout the breast. So you might expect there to be more disease in mastectomy patients. So what we did was to look at a group of patients having wide local excisions, comparing them with mastectomies. Now this study was carried out by Farhad Iqbal, who's one of our students, and he presented at the British Association of Surgical Oncology in November. And what Farhad showed was that in the wide local excision group, 22% of wide local excision patients had further glands, but in the mastectomy group, 3 times as many. And a third of the patients had more than 3 nodes involved. So there were more in the mastectomy patients. And that means there is an argument for being more aggressive with the axilla of mastectomy patients rather than wide local excision patients. I'm not going to say any more about the axilla, but this is what we're doing at the moment. And this is something which could change. This is what we're doing this week. Next year, it may be slightly different. If we find involved glands on ultrasound, then we're doing an axillary clearance. If the ultrasound is normal, then we're doing a sentinel lymph node biopsy. If we're going to consider doing an axillary clearance, then we'll do an OSNA test and decide that at the time of surgery. We're going to use radiotherapy in the axilla if there's a positive sentinel lymph node after a wide local excision. And we're also offering patients entry into a trial of no extra treatment at all. But at the moment, as I say, this is something that could change. I'm going to finish talking about breast cancer in a moment, but before I do, I'm just going to talk about one individual patient. Now, this is a lady who was diagnosed with a fairly unpleasant cancer in 2005. Now, this lady, as well as having breast cancer, had suffered through life with multiple fits. And her husband kept a record of all the fits that she'd had since 1986. So 2005, she was diagnosed with breast cancer. She underwent surgery. She underwent chemotherapy. And then she was started on a drug called tamoxifen. And tamoxifen blocks estrogen receptors in tumours and elsewhere in the body. And the number of fits decreased. She had 2 years of tamoxifen. And after 2 years of tamoxifen, we switched to another sort of drug, exemestane, which is an aromatase inhibitor, and this abolishes production of estrogen in the body. And her fits ceased. 6 years on, she still hasn't had another fit. Now, we've published this. The drug company didn't know anything about it, but I'm just hoping that they'll be able to use our experience with this patient and maybe offer this drug for use in patients with epilepsy. Nothing to do with breast cancer, but I think this is serendipity at work. So now I'm briefly going to talk about surgical training. I've shown you what I did, similar sort of pattern. As a junior trainee in surgery, you learn your operations fairly simply, you learn parts of them, you learn to do the whole thing, you learn how to make the decision about whether or not to take patients to theatre, which is actually the more important one quite often. We had all those years of training. Sir Kenneth Kalman again changed the way that things were done under the New Deal, restricted the hours, took out a couple of levels of the trainee, and this is what we do now. The European Working Time Directive, our junior doctors work a 40-hour maximum. Now, that doesn't say this is an easy way of working, because there are fewer doctors on the wards now, so they're under a lot more stretch. A lot more is expected of them. It's a tough time for those 40 hours. But if you look at just the time, this is what I worked when I first started. 1 in 2, 106 hours a week, 63% of your time on duty. Even a 1 in 3, for example, when I first came here as a senior registrar, I was on duty over 50% of the time. And a long weekend from Friday morning till Monday evening, 81 hours. And you compare the time that doctors spend now in training, it's far less. And in total, less years, less hours, it's about a third of the time. So that means to become competent in dealing with general surgical emergencies, which all general surgeons have to, they have to work really hard. They have reduced hours, so they have to pack in that training, they have to pack in that experience. And the experience has to be so much more focused. And as a result of that, because it's focused training, we have to have specialization, subspecialization, as well as that being ideal for dealing with the different types of cancers. That's all I'm going to say about surgical training at the moment. Now I'm going to talk about Keele. So this is Keele, beautiful summer's day, not like that today, and here's the medical school. But it wasn't always like that. When I first started with medical school as director of admissions, we were housed in these buildings in the covert. Our first link was with Manchester University. We started interviewing in 1999, and in 2002, the first batch were transferred over to Keele. And the Sentinel said it was great for them to be here. These students qualified 3 years later. This was just before they qualified, and they were qualifying with a Manchester MBCHB. The Keele undergraduates with the Keele MBCHB first came in 2007, and they graduated in 2012. And this highly colourful bunch of people are the ones who are responsible for their training. And these are the people who are taking boys and girls from school and turning them into doctors. They've designed the course, they're delivering the course, they're doing a lot of the teaching, a lot of the planning, a lot of the organisation. I've worked with 4 heads of school. Susan Dilley was the head of school who really got us going as a medical school in alliance with Manchester. Richard Hayes was responsible for the introduction of the new curriculum, or the development of the new curriculum, which was introduced by Val Wass. Andy Hassel was the director of undergraduate programs with both Richard Hayes and Val Wass, and knows more about the running of the medical school than anyone else. And I owe particularly thanks to Andy. He has been a huge supporter, and I certainly wouldn't be here without him. So, Andy, thank you very much. I'm based at University Hospitals North Midlands, the Royal Stoke University Hospital. This is it from the air. The education, theoretically, is done in both these buildings, UGMS1 and the Clinical Education Centre. Again, it wasn't always like that. When we first started in medical school, UGMS wasn't built. It was going to be built in that car park, but when they started digging it up, they found a whole load of graves from the medieval hospital of St. Loy's. And that meant that our first students had to be educated in the annex, part of the psychiatric hospital, which was knocked down apart from that. And while that was happening, we were interviewing. We didn't have a medical school on the campus to interview, so we were interviewing them in a funny little building on the hospital campus called the Courtyard Annex. And there's Julian Molyneux, who with her team would run the interviews from there. And to do them justice, we were taking the students around, we were showing them this out, and they were still applying to come to us. So that's when we were combined with Manchester, and when we were standalone, yes, we dropped. Who's heard of Keele? But they started coming, and they continued coming. This was the introduction of the new curriculum, so these were then applying for the Keele MBCHB. You can see the numbers going up until the introduction of university fees, and then it plummeted. Gordon Dent is now running the admissions. It's a modern curriculum, and it was designed together with the GMC document, Tomorrow's Doctors. And it's a spiral curriculum, which means you visit the same subject time and time again in slightly more detail as the students get more experience. We're not a pure problem-based learning course. We have that, but we also have lectures, we have seminars. And the clinical years, they have hospital experience, mostly with us at UHNM, but they all spend a year in Shrewsbury. They all spend time in primary care, in general practice. This year, we're educating 270 students at UHNM, year 3, 4, and 5. And you can see from this how the amount of clinical training goes up year on year. Even the year 2 students come to us for a day a week to be taught in the skills lab about examining patients, taking histories. But by the time they are in year 5, they're spending 5 days a week on the wards, still spending 10% revising the theory. But it's an important time final year. And this is where they're spending time as student assistants, learning the art of being a doctor. They spend 15 weeks in general practice as well. Now, the people who help run the clinical teaching, there's Fiona Leslie, who's Deputy Hospital Dean, Nina Bodasing, who's Year 3 lead, Fidelmo Mahoney, who's Year 4 lead, and Ruth Kinston's Year 5 lead. And these are helped by Stu McBain, Gordon Dent, and Maggie Bartlett. They organise their years of teaching, but really it's a whole number of people, a lot of whom are here in the audience today. And how do these students learn? Yes, apart from the theory, they're on the wards. They go to the emergency portals, A&E, surgical assessment unit. They go to the outpatient clinics, a lot of work done in outpatient clinics. They go to the assessment clinics where we check, for example, whether the patients are fit for surgery. As a surgeon, I'm interested they come to theatre. They assist. We teach them to do things like closing skin. And here you can see one of the students being taught suturing. And importantly, they're taught at the bedside in the presence of patients. The teaching is done by the busy hospital consultants in all these disciplines. Now, these are busy people. We are one of the busiest hospitals in the country, one of the biggest hospitals in the country. We've got the rarities, we've got the commonplace. And so our students see both. And what my job is to persuade these busy clinicians that they have the time to teach as well as to treat their patients. Each student has an individual timetable. They know where they're expected to be every day of the week. Now, as you can imagine with a busy hospital, there are often times when the clinicians have got something else to do as an emergency with no notice. And so I rely totally on our teaching support and admin team to keep everything organised. They keep me in check. They keep us all in check. So I couldn't run this without them. And to keep the quality of the teaching, we rely on feedback. And it may surprise you, Vice-Chancellor, to hear that our students are not reticent in coming forward. Even if we think we're doing something pretty good, they'll tell us if we're not. And we use this to fine-tune some of the individual units and find areas for improvement. But also, we can identify areas of good practice and good teaching. And one of the things that we instigate is the Clinical Teacher of the Year. And here you can see David Gray last year getting his award from Mark Hackett, who's our Chief Executive. As well as teaching them facts, as well as them teaching how to examine and make diagnosis, we need to teach them to be professionals. And we're emphasising the professionalism throughout the course, and especially bearing in mind what happened in Mid-Staffordshire. These students have to be taught to raise concerns. And I'm pleased to see something that just came out this weekend. These are our first-year clinical students, Year 3 students, and 94% of them know how to report a concern if there's an issue of patient safety. How are we doing? I'll come back to the top point. We were first in the NSS, and I'll speak about that in more detail. Most of our students are graduating once they get to final year. If you look at how they're doing as postgraduates, then the trainers who are looking at our Keele graduates reported ours were doing second best of all medical schools in 2014. And in 2012, we were only second to Cambridge with our graduates going on to get training jobs. We didn't do quite so well last year. We were sixth. And if you look at this graph, looks very complex. This is Keele here. The worrying thing is, I was at Edinburgh or Peninsula. What are those doctors doing if they're not in employment? Have they given up medicine? So ours are doing quite well. Sixth in specialist training in the UK. And for some reason which I don't understand, second in general practice and psychiatry. Nothing to do with surgery. But overall, 98% of our patients say they're satisfied with the quality of their course. They think the staff are good at explaining things, made the subject interesting, staff are enthusiastic, which they are, and I know they are, and that the course is intellectually stimulating. And I can promise you we did not write that last statement. But it's not all good. These are things which are areas for improvement. My target is to get every single F1 job, the first year doctor job, filled by a Keele graduate. I'm still hoping we may get it done this year, but at present we're not. The other things that I'm very keen that we keep going, we must maintain the professionalism of our students and graduates. I need to persuade our clinicians that they have got the time as well as the energy to teach. And a lot of consultants still tell me they are teaching for free. They're not. We are paying money into the directorates to get that teaching done. And I'm having service level agreement discussions with the clinical directors to make sure that happens. Now, to be fair, the trusts have this within their 2025 vision. And as well as that, along with their target for 7-day working from junior doctors and consultants. They want 7-day learning. So students, be warned, you will be expected on the wards 7 days a week. As well as that, we need to get our students and our teachers thinking about research and audits. And I'm very pleased when I can marry up 2 areas, breast cancer and research and medical education, and here are some groups of my students who've done research on topics in breast cancer. But overall, at present, we're graduating 120 excellent clinicians every year. And I think that we have the experience, we are giving them the experience, and these are teachable people. I've talked about the teams I work with. What I haven't mentioned is the home team. This was was photograph taken my mother's 90th birthday last summer. I couldn't have done all this without the help of my wife Jane. Huge support, especially years like the liver unit where I was working 1 in 3. Huge support, thank you very much. And within that home team, I'm very proud that we've got a 3-generation of surgeons. And what's important in life? Family and friends. And I'm really grateful for all the friends who've come today, especially those who've made a long journey to get here. We've had some great times and more to come, I think. And then finally, just to finish, the instigation of Professor Dick Strange, somewhere or other, something I'm trying to learn at the moment, astrophotography. And my last slide, apart from the bottom right, which is taken in Iceland, all the other pictures taken from my front garden. Ladies and gentlemen, thank you very much.